In the last video, we were looking at clinical thinking in the emergency department, and we were looking at it in the context of a patient who came in with a headache. And from there, we were able to form our differential diagnosis, as well as compile a list of red flags or illness scripts that we needed to look for during our evaluation, our history, and our physical. And you'll remember that we were using top-down processing in order to make this. We were starting with the diseases with our differential and then compiling the list of details, and these details were our illness scripts or the red flags we're going to look for. Now what do we do? Now that we've done our history and physical, what's the next step? This is when we need to decide which diagnostic testing we're going to order and what kind of treatment and disposition we're going to make. So let's go through an example. So we'll use our headache patient again, and let's say that this is a new onset headache, that our patient had no hard neurologic findings, and with those that no hard neurologic findings, there's also no dizziness or no ataxia. It was kind of sudden in onset. It was kind of maximal. Definitely had nuchal rigidity with it. This is an otherwise healthy person, so there's no coagulopathy, and we're not suspecting this to be a vulnerable patient or any occult trauma. The patient's eye symptoms were pretty unremarkable. No pain, no visual loss. No one else at home had this. Let's say this is a 23-year-old person, so it's not an old lady, and there's no temporal headache or jaw claudication with this. He's not been having progressive daily headaches. He is not immunocompromised. He doesn't know if he had a fever or not, though. He's not been taking his temperature. And obviously, he's not pregnant. So the question you got to ask yourself now is, how much does this patient's presentation match the illness scripts? So we want to know if it matches any of these illness scripts. And a patient's presentation is not going to match perfectly with any of them, but it'll match somewhat. And so we're going to assign probabilities on how much we think it matches. And I like to break it down into 4 categories. And they're going to go from 0% chance that the patient has a disease, so you've ruled it out, to 100% that you've ruled it in. Now, you could really never be 100% sure of anything, and conversely, 0% sure, which means 100% sure it's not that thing. So technically, you will never reach this level because there is no certainty in life. Now, that said, you can actually assign percentages, and the numbers really don't make that much of a difference because these are estimates anyway, so I make categories. And here are my categories. They are no, low, medium, and high. So let me define what each one of these categories means. No means that you're pretty sure that they don't have this disease, or if you don't miss it, nothing bad's going to really happen, and so you're not going to pursue it any further. You're pretty sure that they don't have it. And conversely, high means that you're going to start treatment now. You're so sure that they have this disease that you have no further need for testing. No, also you have no need for testing because you're so sure they don't have it. So you could also say that in this case you've ruled it in, and in this case you've ruled it out. With no, you've ruled it out. With high, you've ruled it in. Now what about these middle 2 categories? So in these categories, obviously, you have not ruled it in, and you've not ruled it out. So in the low one, you have low suspicion, but you're still not willing to rule it out. You need to do some testing. And in the medium one, your suspicion is higher than low, but not enough to start treatment before testing. So you want to do a test before you would start treating that patient to make sure that they have the disease. So these points are commonly referred to as the testing threshold and the treatment threshold, because here at the testing threshold, below the threshold, you're going to do no testing, and above it you are. And for the treatment threshold, similarly, below the threshold, there's no treatment, and above it, you're going to start treatment. So where you set those thresholds really depends on the disease process that you're looking at. So let's take an example of GERD, okay? So reflux disease. And so if you miss GERD in the emergency department with someone who comes in with chest pain, probably nothing bad is going to happen. They may just have a little bit of heartburn. And so you say, you know what, I'm going to set my testing threshold really high. I'm not going to test for it in the emergency department. It doesn't really matter to me that much. So you set the testing threshold high. You may even lower your treatment threshold if the story is pretty good for you. So you know what, giving this person a couple of antacids and telling them to stay away from chili peppers doesn't have too much cost to me, and so I'm willing to lower the treatment threshold. So maybe the zone in which you're testing is going to be pretty small, because we're pretty much never going to be testing for GERD in the emergency department anyway. So now let's look at a different example. Let's look at thoracic aortic dissections. Now this is a pretty terrible disease. If you miss it, the consequences are quite horrible because it's going to lead to death. The treatment for it also is a pretty big deal. It's having thoracic surgery, cutting open somebody's chest. So how would that affect your thresholds here? So here we would move our thresholds, right? The surgery is the treatment for this, and that's a pretty big deal. So we want to be pretty sure that we have it before we commit someone to surgery. So we're going to raise our treatment threshold. Conversely, we're going to lower our testing threshold because a misdiagnosis here equals death. So we have a bigger area in which we're going to test. So our testing zone for GERD is much smaller than our testing zone for thoracic aortic dissection. So one way to look at this is that the testing threshold is kind of set by the cost of missing the diagnosis. The treatment threshold is kind of set by the cost of treating that diagnosis. And there's another cost as well. There's the cost of testing that will also play a role. So if a test is particularly expensive, and I don't mean just by money, it might cause morbidity or mortality. Maybe the test itself is dangerous. That may move up and down your threshold as well. Maybe it's cheaper to just treat somebody than test them, right? You're not going to do pulmonary function testing on someone who's wheezing and they have a history of asthma. You're just going to test them because it's just cheaper to do that. Or the test may be too dangerous. Like, you're not going to get a CT of the belly for someone who was shot in the belly. You know what? They just need to go to surgery. The cost of testing, meaning waiting with someone who's bleeding in their belly, costs way more because they might die from going just straight to surgery and opening them up. Okay, I took us on a little bit of a diversion from where we were, so let's come back. If you remember, we were going to divide our suspicion, our probability, our pretest probability, this is called, into 4 categories: no, low, medium, and high. So let's just go look at our differential again and assign probabilities there. So these were all the diseases that were in our differential that we're looking at. So let's quickly go through our differential. I didn't give you all the details just to make this video not take forever, but let's say we did not think this person had a stroke. There's no hard neurologic findings. Young person, no medical illnesses. And we also didn't think that they had a cerebellar infarct. A subarachnoid hemorrhage, well, maybe they do because they do have some nuchal rigidity. The headache was sudden onset. That one's pretty good. We're not ready to call that high, meaning we're not going to call neurosurgery just yet. We're going to need to do something about that one. The artery dissections, we don't think so. There's no neck pain. And the epidural and subdural hemorrhage, we're going to say no, low. Maybe he hit his head and he's just not telling us, but we don't. We need some more testing for that. Glaucoma, a young guy, no eye pain, probably not. Carbon monoxide poisoning. I am recording this in winter, and so maybe he just turned on his heat, and so we have some low suspicion for that, so we got to look into that a little bit more. Temporal arteritis, a young guy, no. Tumor, it's not been progressive, and he has no neurologic findings. Meningitis, okay, he does have nuchal rigidity. He doesn't remember having any fever, so we'll maybe put that medium. Okay, and obviously he's not pregnant, and he's not hypercoagulable that we know about, so for dural venous thrombosis, we're going to say no. So again, these are considered our pre-test probabilities. Before we do any testing, this is our probability that they have the disease, and it's based mostly on our history and physical. Okay, I cleaned up our list a bit so that it's a little bit easier to see what are the diagnoses that we're working with. Now, we need to talk about how you go from pre-test probability to test selection, diagnostic test selection. Because the way that you interpret a diagnostic test completely depends on your pre-test probability. Let's take a very easy example. Let's say this blood test is a D-dimer test. That's a test that looks for blood clots like a DVT or a pulmonary embolus. And let's say that that test came back negative. Now, the way that you interpret that negative test completely depends on your patient. Say that our patient is a runner, an otherwise healthy woman who has no medical problems, who shows up with calf pain. She's on birth control pills, which is why you are even entertaining this diagnosis of a DVT in her. So you send off the D-dimer and it comes back negative. So after that negative test, what do we think? Is this a DVT? No, of course not. We had low suspicion to begin with our negative test there. For DVT, now our suspicion is low. Is no, we don't think it. We're done. Go home. You strained it when you were running. Let's take a different patient, though. Now, this is a patient with lung cancer, and maybe he's even had a DVT before. Not completely clear that he says, I don't know that it feels like my prior DVT, but my legs do hurt. Uh, and so your suspicion ahead of time is medium. So you do the test, the D-dimer, and it comes back negative. It's the same one. So what is your suspicion for DVT here? Is it no? Can you rule it out? No, of course not. This person is at much higher risk than this person. And so a negative D-dimer, it doesn't knock me down below that threshold where I can rule it out. And so, no, this test does not help in this case. And so this exact same set test, the D-dimer test, a negative result, the exact same result, the way you interpret it matters. It's totally based on your pre-test probability. So we go from a pre-test probability, the diagnostic test, to the post-test probability. And the way we interpret this diagnostic test completely depends on the pre-test probability. And so don't worry about the mathematics of it or anything. Just try to think of it intuitively. If you have a really high suspicion, it's going to take a lot of evidence to convince you otherwise, right? And if you have very, very, very low suspicion, it's going to take a lot of evidence to convince you otherwise as well. And so your initial suspicion matters. It matters a lot. And tests can be wrong, and a lot of times they are wrong. So let's move this out of the way and go back to our case. Now, let's see what we would do. So our initial thing was for subarachnoid hemorrhage, right? And we had pretty medium suspicion for that. What test do we want to get for that? Because we are not yet convinced that we're going to start treatment. We said that we need to do some testing first. So a plain CT of the head is what you need to do. And how good is that? Well, if it's within 6 hours, it's pretty darn good. A negative test here means we're done. We're at no. What if the test is positive? Well, then you need to call neurosurgery. What if you have a positive CT at more than 6 hours? Same thing. You need to call neurosurgery. That means we're pretty good. We pretty much think that this is a bleed. What if it's negative? In this case, it's not that good. Then you need to do a lumbar puncture to look for bleeding. And then based on that, again, you can say, well, if the lumbar puncture is positive, I'll call neurosurgery. If it's negative, then I'm done. I don't think it's a subarachnoid hemorrhage. Now, what about epidural and subdural hemorrhage? Our suspicion, you remember, was low. So again, we're probably going to get a CT of the head looking for bleeding there. And again, we only need a plain one if this is an acute trauma, because we should be able to see bleeding very easily there. And you always ask yourself, what do I do if the test is positive? What do I do if the test is negative? If it's positive, well, then they need surgery again, right? So we'll call our neurosurgeons down. If it's negative, I feel pretty done. I feel like this is not going to be a head bleed because this guy doesn't report any trauma. I'm done. I'm going to say no. Okay, what about carbon monoxide poisoning? We can do something called co-oximetry, and that measures your carbon monoxide level. Kind of looks like a pulse ox. So what if it's positive? Well, then we need to treat. And so that means giving this person oxygen. But it also means getting rid of the source of that. So we need to call the fire department to go check out this guy's house. And what if it's negative? Well, we probably wouldn't treat with oxygen, but maybe it's negative just because by the time he got here, his level dropped again. So maybe you still want the fire department to go to his house. So the fire department can go there and measure carbon monoxide levels and make sure that they're not high. And then next we'll look at tumor. And what do we want to do for the tumor? We might also want to do, again, a CT head. And our suspicion was low. So if obviously it's positive, he's probably going to need surgery and need to be admitted because he's going to need this worked up. If not, then since my suspicion was low, I'm going to be done. I'm going to say, no, it is not a tumor, and I'm not going to pursue that any further. Finally, let's look at meningitis. What test would we want to do for that? We're going to do a lumbar puncture. But this one, time is very important, right? So we have a different initial action. If we are considering meningitis highly, then we need to give antibiotics quickly. So maybe you're going to do the antibiotics first, all right? And then you're going to do the lumbar puncture, right? And then if the lumbar puncture is positive, then they need to be admitted for more antibiotics and until they get better, because we're going to get IV antibiotics, right? And if it's negative, then you say, okay, fine, I'm done. You can go home. Yes, I gave you a dose of antibiotics that you didn't need, but my suspicion was high, and I didn't want to wait until I got the results of this before treating you. Now you can see how our differential and our pretest probabilities determined what we were going to order. Right? We didn't just go shoot from the hip and say, yeah, give me this, give me that, give me a CT head with contrast, give me a neck films, give me... No, there was an order to this. We were worried about subarachnoid, and because of that, we got a CT head, and we had a plan on what we were going to do based on those results. For this epidural hemorrhage and subdural hemorrhage, we still had the same plan at CT head. For our carbon monoxide poisoning co-oximetry we were going to do. And we were going to let the fire department go to his house and check it out too. Tumor, CT head. And we're going to do a lumbar puncture for meningitis. Obviously, I didn't list everything that you're going to do. Like, you're probably going to want to get blood cultures for the meningitis. You're probably going to want to get a CBC. But you get the idea that what you order depends on your pre-test probabilities. And then you interpret your test in light of the pretest probability. So let's give you some results. Let's say you get your CT head. Your CT head was negative. And so you thought that this was not going to be, and it was within 6 hours. And so you said, this is not going to be a subarachnoid. I told you it was negative. So here you don't think that it's a subdural. And your co-oximetry was also negative. So you called the fire department. They go check out his house, and it was normal. And actually, he even had a carbon monoxide poison he installed a while ago, but he forgot about it. You also, the CT head we already talked about was negative here for the tumor. And finally, for meningitis, you ended up giving him some antibiotics, and he ended up having nothing there as well. And his headache just gets better with some Tylenol. And it turned out to be nothing. But look at the long process we had to go through to get there. We had to make sure it was none of those bad things. And so thanks for watching. This concludes our video on clinical thinking in the emergency department. Let me know in the comments what you think. And good luck on your rotation. And thanks for watching.